Good morning, everyone. Our topic today is Palliative Interventions Part 1. Part 2 is already been given, and it's basically the interventional cancer pain management. Objectives of this presentation: definition, introduction, risk versus benefits, palliative surgery and endoscopy, palliative radiation, palliative chemotherapy, and we'll conclude with key learning points. Definition: invasive palliative intervention is any procedural injury of the body with primary aim to alleviate and to directly improve patient suffering. Introduction: the number of the patients surviving a long time after diagnosis of non-curable digestive cancer is continuously increasing. Most of these patients need to be supported by further treatments, aiming to improve the quality of life. It is extremely important to identify the borders between curable and non-curable cancers through accurate staging procedures. In patients not curable or not responding to therapy, the palliation of symptoms is essential, involving a multidisciplinary team. Mistakes in this evaluation can result in giving anti-cancer treatments to patients with non-curable diseases, and on the other hand, deprive a curable patient of proper and effective treatments. This is a source of cases over or under treatments. Before we get into the subject here, we need to ask ourselves, what are the risks and what are the benefits? Before deciding to propose a palliative treatment, the oncologist should consider the following points. Give the correct information about curative potentials of surgery, radiotherapy, chemotherapy, or monotherapy, immunotherapy, and possible therapeutic combinations, and any other kind of certified treatments. Evaluate the risk factors relevant to circumstances of a particular patient. Consider the side effects of a treatment and weigh up the pros and cons, especially the likely quality and duration of the remaining life of the patient. Weigh up the likely impact of therapeutic procedures with regard to the expected benefits. Palliative surgery. This is a quote from Dr. Theodore Belworth in 1881. And basically he's saying, I hope we have taken another good step securing unfortunate people regarded as incurable, or if there should be recurrences of cancer, at least alleviating their suffering for a time. So some of the surgical procedures that are used in palliation here is drainage procedures for ascites, pleural effusions or pericardial effusions, laparotomy and laparoscopy, and bypass or resection for relief of biliary or bowel obstruction, resection of tumor, debulking for relief of pain, constitutional symptoms, control of odor, endoscopic interventions for stenting and obstructed lumen, ablation of a tumor or hemostasis, gastrostomy, PEG tube placement for relief of obstruction, hunger, or feeding, craniotomy for excision of symptomatic metastasis or for hemorrhage, fixation of pathological fracture. Other surgical procedures could include major amputation for painful non-viable extremity, tumor embolization procedures, surgical procedures for metastatic spinal cord compression, suprapubic cystostomy for bladder outlet obstruction, simple mastectomy, sometimes they call it toilet mastectomy, tracheostomy, biopsy procedure to guide palliative treatment, and vascular access procedures for medication administration, dialysis, and parenteral nutrition. We'll start with fractures or imminent fractures of long bones. And in this situation, we use a criteria called the Merrill criteria. And basically, if you score more than 8, this will suggest a prophylactic fixation to the patient will be required. And they're basically, the score is 1 to 3, and there are 4 entities here, and they're looking at the site, the pain, the lesion, and the size. Okay. So as you notice here, for example, lower limb takes a larger number than upper limb, and perimeter can take more than both of them. So the reason is these are weight-bearing bones. So if you lose them, you will be non-ambulating. While upper extremity, you can still function around with a broken arm. Okay, you can fix it with a somewhat and you can continue your life. But once you break your legs, you're not going to be able to ambulate. That's why it's getting a higher score, and so forth. A lytic is worse than blastic because, of course, lytic more liable to get fractured than a blastic lesion. This is one of the surgeries that been done for, fractures. It's called the pinning of the femur. Okay. So as you see, for example, here the tumor is on the left here, and then they're putting a metal rod, and this will fix the area and support the bone to prevent a fracture. Another similar to the Merrill criteria, similar score, is called the SINS, Spinal Instability Neoplastic Score. If you look at it, I mean, it's more comprehensive, but it's carrying the same, entities like the Merrill criteria. Okay, we'll jump into types of central venous catheters that we use in palliative setting here. Non-tunneled central catheters, we have tunnel, we have peripherally inserted central catheters, and we have implantable ports. By definition, a central catheter is a catheter that's introduced down to the lower 1/3 of the superior vena cava. Okay. Of course, this first slide, these are not central catheters. These are just peripheral catheters. And I just put them because these are the ones that we prefer in palliative setting. But let us say the patient came with a central line. We can still use it, okay? But our preferable sites are peripheral IV, midline. The midline is a long peripheral IV. It's not a central line, okay? And we insert it under ultrasound guidance. And then we have a subcutaneous route, which we use usually a butterfly, in the subcutaneous area. All of these routes are pretty safe and not aggressive measures in our, agenda here as a palliative care. Okay, Now we have other central lines. I just showing you some of them here. We have the Hickman, which is externally tunnel. Part of it is out, part of it is in. A PICC line, and this one is inserted from the antecubital area. And this one is also placed in the lower one-third of the superior vena cava. We have the portocath, which is completely implantable. Other procedures that are needed in palliative setting is something like pericardiocentesis for malignant pericardial effusion. Of course, we get assistance from our fellow cardiologists here to do this procedure. Thoracocentesis. And this is a very common problem that we encounter is pleural effusion, malignant pleural effusion. And paracentesis, also for patients that having ascites, such as advanced liver cirrhosis, for example. And we use different types of catheters. We use this pigtail catheter, which is a small size catheter. And also we have something called the Denver drain, which is somewhat larger caliber. In palliative setting, you might need also tracheostomy. I mean, it's not like, we will let the patient die suffocating here because there's a palliative patient or end of life or whatever. If he needs a tracheostomy, he will get a tracheostomy. Okay, this is ABC. Sometimes you need bronchial stenting. This is done, of course, by the pulmonologist here. Endoscopic treatments. This is a major part of this presentation. The gastrointestinal tract has cavities that function as containers or as canals. Tumors reduce the space available and impair the functions of containing and transit. Containing like stomach, transit is like esophagus and intestine. Their function is transit, while containing is the stomach. Moreover, tumors infiltrating and ulcerating the walls of these cavities cause hemorrhage, obstruction, perforation, and fistula formation. The most important symptoms of digestive tumors are dysphagia, odynophagia, salivation, vomiting, jaundice, pain, constipation, and hemorrhage. All these symptoms can be treated by endoscopic modalities. There are different ways to achieve relief from symptoms. The physician must be able to discuss with the patient the different symptom relief methods available so that the patient can choose the one that fits better with preferred lifestyle. For example, esophageal stenosis can be relieved by a nasogastric tube, or by laser or other thermal treatment, by gastrostomy, by stent insertion, or palliative chemotherapy. Patients must be informed about these options so that they can decide which one is the most suitable for their way of life. Features of endoscopic palliation. Achievement of an immediate result in the control of the symptoms and restoration of normal function. Also, palliative treatments should be tailored to the individual patient and to the patient's capability to undergo these treatments. Also, the endoscopic palliative treatments aim to obtain the best possible quality of life with immediate and durable benefits with negligible trauma. Although the primary purpose of all these palliative procedures is not to increase survival, the good news that the treatment of severe symptoms, whether it's nutritional or respiratory or metabolic, very often results in an effective extension of survival. Some of the tools that we use during endoscopic palliation, First, dilation can be performed using a pneumatic balloon dilators, metallic olives, and plastic bougies. Laser treatment aims to reopen esophageal lumen, for example, through the thermal coagulation destruction of the cancer tissue. Photodynamic therapy uses intravenously injected photosensitizing drugs from the group of porphyrins that are selectively fixed by the tumor tissue. Cryotherapy is based on a sudden reduction of local temperature in the tumor mass. And this reduction of the temperature is obtained using special probes. The effect of sudden reduction in temperature is that the bleeding will stop and the tumor necrosis is produced, so as to temporarily reopen the esophageal transit. This is like a laser machine. And this is photodynamic therapy. A person with the cancer receives a drug called photosensitizer. In 24 to 72 hours, cancer cells absorb the photosensitizer. Cancer cells that absorb the photosensitizers are exposed to light. And light causes photosensitizer to make a form of oxygen that kills the cancer cells. Other tools, argon plasma, which is a jet of argon gas switched from argon plasma, is directed to the tumor surface under endoscopic control to coagulate the bleeding surface. So this is kind of an alternative to laser. Transendoscopic adrenaline injection is sometimes used to control bleeding, and then prosthesis introducing a stent after a reopening stenotic tract prevents an early recurrence of the obstruction. Inserting an expandable stent is no more traumatic than performing a normal flexible esophagoscopy. Prosthesis. The best results are obtained when the prosthesis does not interfere with the mechanism of the sphincter, the pharyngeoesophageal or the cardiac sphincter. When the cardiac sphincter is infiltrated by the tumor and prosthesis keeps it open, the natural anti-reflux mechanism is impaired and the gastric content flows back to the esophagus. The acid gastric secretion can be responsible for supraprostatic esophagitis, and this condition causes dysphagia, even though the esophagus is patent. However, in patients submitted to gastrectomy, the reflux through the prosthesis may give rise to an alkaline esophagitis. So, I mean, unfortunately, some of these, complications of, putting a prosthetic is to get this esophagitis. Okay, so some types of endoscopic palliation here is esophageal stenting for malignant esophageal obstruction, gastric outlet stenting for gastric outlet obstruction, percutaneous endoscopic gastrostomy, colonic stent, stenting of malignant hepatobiliary obstruction, and interventional endoscopic ultrasound. A nasogastric tube. Treatment of dysphagia and its sequelae is based on crossing the obstacle and that prevents the passage of food. And this can be achieved by a nasogastric tube, by restoring the esophageal lumen by dilation, laser treatment, photodynamic therapy, endoscopic injection of chemotherapeutic drugs, or even endoluminal brachytherapy. All of these different options have specific indication. The purpose is inserting the nasogastric tube is feeding liquid food. The indication is restricted to cases in which the stenotic obstacle cannot be dilated more than 4 to 8 millimeters, and mainly happens when there is a post-operative or post-radiotherapy fibrotic stenosis that makes forced dilation dangerous as there is possibility of perforation. There are several disadvantages of nasogastric tube. First, aesthetic, patient is obliged to live with the tube coming out of the nose. Functional, the external surface of the tube adheres strictly to the inner surface of the stenotic tract, and this prevents saliva from being swallowed, leading to salivation. Um, Sensuous, with food introduced through the tube, the patient is unable to enjoy the taste, one of the few pleasant sensations remaining at this stage of life. Patient complains of these disadvantages also after the creation of gastrostomy or jejunostomy. Nasogastric tube. We have different types of nasogastric tube, like the Salem sump, which is like a double lumen tube, one for gastric aspiration, and one for feeding. Then we have something like Dobhoff tube for feeding, Ryle tube. This is the one on the right is Ryle tube, commonly used in Egypt here. Esophageal stenting. This is an important topic and has been recommended by the European Society of Gastrointestinal Endoscopy, ESGE. Uh, you know, they recommend placement of a partially or fully covered self-expandable metal stents, SEMS, for palliation of malignant dysphagia or over laser therapy, photodynamic therapy, and esophageal bypass. ESGE recommends esophageal SEMS placement for sealing malignant tracheoesophageal or bronchoesophageal fistulas. For example, this is one used for obstruction in the esophagus here, a metallic stent, SEMS. This is with using the endoscopic to place it. As you can see, it's well placed in the esophagus here. These are the some of the types of SEMS. There are more types that I did not bring here in this presentation because we're not, gastroenterologists. We're not going to get too deep in these issues. But I want you to have an idea what is bare SEMS and what is partially covered and what is fully covered. You can see it on the left of the picture here. And not only this, some of these SEMS have anti-reflux valve to prevent the food to come back to the stent. And there are other types, as you see in this nice picture. Okay, indications and contraindications for stent use in the esophageal obstruction due to malignancy. So indication. Actual or impending fistula, unresectable malignant obstruction, tumor recurrence after surgery, malignant gastroesophageal anastomotic leaks, contraindication to chemoradiotherapy, extrinsic esophageal compression by primary or secondary mediastinal tumors, potential for significant airway compression, uncorrectable coagulopathy. These are the contraindications. Potential for significant airway compression, uncorrectable coagulopathy, tumor or stricture within 2 centimeters of proximal esophageal sphincter, recent high-dose chemoradiotherapy, curable disease by multimodality treatment, and terminal ill patient with limited life expectancy. Feeding after esophageal stenting, this is an important topic for palliative physicians because probably the patient will end in the palliative unit after he or she receives the stent. So you need to be aware about how to do the feeding. And it goes into three stages: stage 1, 2, and 3. With stage 1, you start with fluids only and small sips. Stage 2, you start smooth or pureed foods, including soup, applesauce, yogurt, ice cream, pudding, or gelatin. Stage 3, try to include a wide variety of foods and fluids in your diet so you can achieve as close to a normal diet as possible. Complications of esophageal stent: pain in the esophagus, uh, bleeding, perforation, migration of the stent, tumor growth into the stent, and GERD. Remember, we talked about these, stents can cause esophagitis. Gastric outlet stenting, as you see here, the stent at the gastric outlet. Again, this is for gastric outlet obstructions. Another endoscopic picture for the stent, well placed in the gastric outlet. Complications of gastric outlet stenting is similar to esophageal stenting: bleeding, perforation, migration, severe pain. And you add to it is jaundice, is because you can induce biliary obstruction with this stent because you're very near to the duodenum and the opening of the biliary tract. Colorectal cancer also in advanced stages, you can place a colonic stent, which will help with, basically the process of defecation. PEG tube insertion. It's one of the most important and controversial areas in palliative care. A PEG tube or percutaneous endoscopic gastrostomy feeding tube is the placement of a feeding tube through the skin and the stomach wall. It goes directly into the stomach. You can do it through endoscopy or through X-ray, using interventional radiologists to place it for you. And basically, it's mainly indicated for patients that have an inability to move their food from their mouth to their stomach, such as a stroke patient, amyotrophic lateral sclerosis, cerebral palsy, and patients with impaired swallowing. Care of the PEG tube is important. Same token like feeding after these and the insertion of these tubes. The care of these tubes are important for palliative folks because you're probably going to be handling these after they're being inserted. So usually drainage around the PEG tube is common for the first 1 or 2 days. The skin should heal in 2 to 3 weeks. You will need to clean the skin around the PEG tube 1 to 3 times a day, usually using a mild soap or water or sterile saline. Try to remove any drainage or crusting on the skin and the tube and be gentle. If you use soup, gently clean again with plain water. Dry the skin well and clean with a clean towel or gauze. Take care not to pull out the tube while you're doing this, cleaning process. PEG tube insertion. This is how it looks like at the end of after being placed. As I said, it can be placed endoscopically and may be placed through interventional radiology. Absolute contraindications: patients with coagulopathy, severe ascites or peritonitis, patients with gastric outlet obstruction. It doesn't make sense to put a PEG tube in somebody that has a gastric outlet obstruction, and severe gastroparesis. Classification of, we're going to talk about hepatobiliary obstruction here. So we have two diseases. One of them is cholangiocarcinoma, and the other is pancreatic carcinoma that are blocking, could be potential blockers for the hepatobiliary system. So as far as the cholangiocarcinoma, we have different types. We have intrahepatic, we have perihilar, and we have distal. The perihilar and the distal are extrahepatic. So we have intrahepatic, we have extrahepatic. The extrahepatic is either perihilar or distal. And this is just give you 6 types of perihilar obstructions. Malignant hepatobiliary obstruction, we should first confirm the diagnosis endoscopically or ultrasound guided, to make sure whether this is a pancreatic tumor or cholangiocarcinoma. Number 2, we need to know whether it's operable or not operable, like looking at the vascular invasion, metastatic disease by doing an MRCP, MRI, a pancreatic protocol, or PET-CT. Operable with high bilirubin, ERCP with a plastic stent insertion. In this situation, we need to put a stent. Inoperable, we'll place a metallic stent. So if it's operable, we'll do a plastic stent. And if it's inoperable, we'll do the metallic stent. Okay? Because it can stay longer. The plastic stent is shorter. So it's used, as just like for short term until they do the actual surgery. Okay, but if it's an inoperable case, we place a metallic stent. And as we said, there are different types. There's the uncovered, there's the partially covered, and there's the covered ones. And this improves the hyperbilirubinemia, and then you proceed with chemotherapy. Of course, you have to add some antibiotic prophylaxis and treatment of cholangitis. And this is basically the ERCP here, endoscopic retrograde cholangiopancreatography. And as you can see, you place it, through the stomach here. And of course, you have different instruments that you can use to open up or dilate these obstructed areas. As you see here on the left, a bendable lighted tube endoscopy is placed through your mouth and put in your stomach until the first part of the small intestine, which is the duodenum, to examine the pancreatic and bile ducts. A biliary stent, very nicely placed one here. Complications, ERCP related or stent related. ERCP related, such as complications with the ERCP may be due to endoscopy itself, example pancreatitis, or due to anesthesia, example hypotension. Stent-related common complications of biliary stent placement include stent occlusion and stent migration. Less common complications include cholecystitis, cholangitis, perforation, and bleeding. Stent occlusion include tumor ingrowth or regrowth. Stents may become occluded by the ingrowth of the tumor. Tumor overgrowth is the tumor burden increases the tumor overgrowth. That means occlusion of the ends of the stent by the tumor can cause stent occlusion. And number 3 is the luminal impaction from biliary sludge. Biliary sludge can collect within the lumen of a metal or plastic stent, resulting in a stent occlusion. Stent occlusion is managed by a balloon sweeping the stent lumen to remove the sludge or debris, or by placing a second stent within the lumen of the obstructed stent. So again, the stent occlusion managed by either balloon sweeping the stent lumen or by placing another stent inside the lumen of the obstructed one. Stent migration, and this is also very common. So stent occlusion, stent migration. Stent migration, patients with the stent migration typically presents with abdominal pain, elevated liver enzymes, in a cholestatic pattern or cholangitis. Abdominal imaging with CT can be helpful in determining if the biliary stent has migrated or not. However, if a patient develops cholestatic liver enzymes and or cholangitis after biliary stent placement, we often proceed directly to repeat ERCP to confirm that the stent has migrated. During the ERCP, the malpositioned or migrated stent can be removed or replaced. Other complications include cholecystitis, cholangitis, bleeding, perforation, and pancreatitis. Endoscopic ultrasound-guided biliary access and drainage. As far as pancreatic cancer, as you know, pancreatic cancer also causes a lot of abdominal pain, and it's a typical type of pain, a visceral pain that radiates to your upper back, and sometimes you have to intervene and do a block. And one of these blocks, you can do it under endoscopy. Endoscopic ultrasound is the celiac plexus block. So you can also do it percutaneously, but of course the GI people will do it, endoscopically through the stomach, and they can inject ethanol, and they have a very high success rates, up to 80% success with ethanol. Urinary retention can be also one of the main topics here. You can deal with it with a Foley, a suprapubic cystostomy, a percutaneous nephrostomy. I mean, you're gonna hear these terms. I'm just throwing these things here because as a palliative physicians, you're gonna deal with these cases. Okay, so you better understand what's going on here. I mean, it's not just about giving palliative measures. You need to understand what is a percutaneous nephrostomy and the implications, and what are you going to do, let us say, if it gets obstructed, for example. Okay, so of course you have to be communicating well with other teams, like urologists or gastroenterologists if it's the case of a GI tumor and so forth. A double J, you probably heard this term a lot, double J ureteric stents. Okay, palliative radiation. A palliative radiotherapy is a shortened course of treatment which will usually induce enough tumor shrinkage to relieve symptoms. Indicated in bone pain, spinal cord compression, pungation, cutaneous spread, relief of obstruction, superior vena cava, airway, esophagus, brain metastasis, and to reduce tumor bulk. Sometimes by reducing the bulk, you reduce the pain. And there are different, regimens. Nowadays, we try to use short, short courses, like sometimes in long bones we use a single dose, okay, uh, which could be as effective as multiple fractions. Because I mean, these folks, I mean, it could be very difficult to keep taking them back and forth to the radiotherapy suite and so forth. Also, in esophageal cancers and rectal cancers, external radiotherapy and endoscopic brachytherapy are used to reduce the tumor mass. Palliative chemotherapy, okay, palliative chemotherapy. So palliative chemotherapy is given without a curative intent, but simply to decrease tumor load and increase life expectancy. For these regimens, a better toxicity profile is generally expected. Minimizing potential toxicity is the goal. Try not to compromise on quality of life. Dose reduction to avoid toxicity is permissible. Perioperative adjuvant or neoadjuvant chemotherapy with malignant, uh, with multi-agent regimens, also in association with radiotherapy, is used to treat cancers located in the esophagus as well as stomach, liver, pancreas, colon, and rectum. These treatments aim to reduce the size of neoplastic masses and to restore the transit. Key learning points from this presentation. Invasive palliative intervention is any procedural injury of the body with primary aim to alleviate and to directly improve patient suffering. Role of endoscopic interventions for elderly in palliative care is growing. Palliative chemotherapy is given without curative intent, but simply to decrease the tumor load and increase life expectancy. Palliative radiotherapy is shortened course of treatment, which will usually induce enough tumor shrinkage to relieve symptoms. Multidisciplinary approach is mandatory for managing elderly in palliative care, pain management, radiation therapy, geriatrics, oncology, gastroenterology, and surgery. Thank you.